Good morning, everyone. This is Kim, your host, with your 5-minute warning. We will begin our webinar in just 5 minutes. Thank you so much for joining us. Again, if you're just joining us, welcome. We are just about ready to get underway at 9:30 sharp. Thank you. I'll be back in just a couple of moments to begin. Good morning and welcome to the webinar. Today's topic is posterior cortical atrophy, an atypical form of Alzheimer's disease. And we have a wonderful speaker, a wonderful expert today, and I'm going to tell you about her in just a few minutes. But first, I want to thank our sponsors. This webinar and others like it are brought to you by Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And I'm Kim Bailey, a gerontologist with Alzheimer's Orange County, and I will be your host today. Today, our presenter is going to be Dr. Victoria Pellick. And before I tell you about her, I want to tell you what we need to do to have you earn your CEs. So we do make available CEs through RCFE, VRN, and CAMF. You must be online for 60 minutes, logged in at the start of the webinar. You must have access to both audio and visual components. We ask that you not share your link with others. It is your unique record of attendance. And if you do share it or use someone else's link to join, you will not be able to receive CE credit. There are a series of poll questions throughout our discussion today, and this is proof of your attendance. So as soon as you hear me talk about the poll question, you need to address it and answer it. If for any reason you have difficulty submitting your response, you can always put your answer in the chat box, but please do answer so that you can get your CE. We will have a survey that will come up immediately as you exit the webinar, and it will also come later by email, but we need you to complete and return that survey immediately as you exit, and that will assure you that you will get your certificate of completion via email within 10 days of your completed survey being received. Just some basics for everyone. Everyone's mic and video are disabled, so you can't use the raised hands or any of the other features. However, the fact that you're disabled doesn't mean you can't ask questions. We're devoting a special Q&A time for questions at the end of the seminar. So you can type your questions into the chat box located in the Zoom toolbar. And as I said, we're going to save those questions for Dr. Pellick later. Okay, so now let me tell you about Dr. Pellick. Dr. Victoria Pellick is a professor of neurology and ophthalmology at the University of Colorado School of Medicine with subspecialty fellowship training in neuro-ophthalmology and subspecialty certification in behavioral neurology and neuropsychiatry. She specializes in assessing and treating patients with visual problems related to neurological diseases, and she has clinical expertise in vision symptoms related to Alzheimer's disease, posterior cortical atrophy, Parkinson's, and other similar disorders. She built and founded the Brain and Vision Laboratory at the University of Colorado School of Medicine in order to study higher order visual perception. And she has a particular research interest in visual motion processing. She sees patients at the Rocky Mountain Lion's Eye Institute at the University of Colorado Hospital Outpatient Pavilion, located in Aurora, Colorado. Dr. Pellick completed her medical degree in her hometown of Detroit, Michigan at Wayne State University School of Medicine, and her residency in neurology and fellowship training at the University of Pennsylvania. Dr. Pellick currently has ongoing studies related to PCA, including the Colorado PCA Bioregistry Study, which gathers clinical data, brain and retina imaging data, and the biological specimens that help to better characterize the PCA syndrome. Dr. Pellick feels that it is exciting to be part of discoveries that will make a difference in the lives of different patients, and she looks forward to leading the way with innovative research that has a positive impact on those devastating disorders of aging. So with that, I introduce you to Dr. Victoria Pellick, and Dr. Pellick, you can take over the presentation. Thank you for being with us.
Thank you so much, Dr. Bailey. I really appreciate it. And I look forward to sharing as much information as I can about the posterior cortical atrophy syndrome. And I'm really excited that the Alzheimer's Orange County felt that it was important to bring this topic to your webinar. So first, I want to just go over our learning objectives today, and I hope by the end of the session, you'll be able to understand that visual dysfunction can be due to brain issues in the clear absence of any ocular or eye issues. And at the end, be familiar with the posterior cortical atrophy syndrome as a syndrome specifically due to Alzheimer's disease. And we'll get into some of those details shortly. So first, let's start with the fact that PCA is a syndrome and not a disease. So what do I mean by that? A syndrome is really a constellation of clinical symptoms and sometimes clinical biomarkers, as well as clinical signs, but it is not a specific disease. A disease would be a condition such as Alzheimer's disease or Parkinson's disease, because that's defined specifically by what we'll call the pathology that we find, which you can look under the microscope to see, or a pathology that is present in a blood test or a spinal fluid analysis. So PCA specifically is not a disease, it's a syndrome. And in PCA case, it is due to Alzheimer's disease more than 75% of the time. And what is meant by syndrome versus disease will start to become clear as I talk about this. So we almost always consider a presentation of posterior cortical atrophy as an atypical presentation. And again, since PCA is more likely to be due to Alzheimer's disease than any other disease, we often refer to it as atypical Alzheimer's disease. And just a quick warning, you'll hear me say PCA quite frequently as the abbreviation for posterior cortical atrophy syndrome. So exactly what is it? How do we define it? Well, in a nutshell, it's a condition or a syndrome that presents with severe difficulty processing visual information. It can present slightly varied in its manner, but just to give you the sort of the 14,000 foot overview, and I use that term because Colorado is full of 14,000 feet mountains. So the severe difficulty in processing visual information is really how this condition first presents itself, while at the same time, there's relative preservation of memory, language, executive, and behavioral functions, which you can see right away that that's atypical for Alzheimer's disease, which we think of as initial presentation of memory problems. So now, why do we call it posterior cortical atrophy? Well, it affects the back part of the brain or the posterior part of the brain. I have that highlighted here a little bit in red in our diagram of the brain. And this area that's affected is mostly cortical cells, and the cortex is that wrinkly or sort of folded over part of the surface of the brain. So that's called the cortex. And the term atrophy is there because cells are lost. So neurons die, and they die in the posterior region of the cortex. And so that's where that name comes from. Unfortunately, we don't know the actual prevalence of the disorder. We're getting closer to understanding that, but at this time, suffice it to say that it likely represents, if we're talking about Alzheimer's disease, approximately 5% of patients with Alzheimer's will initially present with the PCA syndrome. There's some thoughts that it may be much higher, but it's just poorly recognized. And you'll get a flavor for why it's poorly recognized when I review it a bit further, or for those of you living with posterior cortical atrophy or have a family member living with posterior cortical atrophy, you probably understand very well how it can be misdiagnosed or misunderstood at onset. So let's look at just atypical Alzheimer's disease in general. We know that about 25% of people with Alzheimer's disease will not present in the typical fashion. They'll present with something other than memory problems. And that's why we refer to it as atypical Alzheimer's disease. So as an example for posterior cortical atrophy, people will initially present with visual symptoms, followed by executive and language difficulty, and then memory, and in the late stages, behavioral problems. It isn't always exactly like this once the visual symptoms are started, because memory could come after visual symptoms. But this is just an example of what we see. Now, when it comes to another condition that we label primary progressive aphasia, in some cases, people with primary progressive aphasia can have that due to Alzheimer's disease. And that can start with language, and then executive, and then visual and memory difficulties, as well as behavior problems. And you may have heard recent news about celebrities such as Bruce Willis, who presented with primary progressive aphasia, but not due to Alzheimer's disease, due to a condition called frontal temporal dementia. But Alzheimer's can also present with primary progressive aphasia. And then two variants that are similar in many ways, but are different, are the dysexecutive variant and the behavioral variant of Alzheimer's disease. So again, the presentation is very different than memory onset. So I wanted to give you this overview so that you know that atypical Alzheimer's disease doesn't always present with visual symptoms. It can present with language, executive, or behavioral symptoms as the initial presentation, with relative sparing of other cognitive domains. What I mean by other cognitive domains are the executive functions of our brain, the language functions, and the memory functions. So I want to give you some food for thought about this whole idea of atypical presentations. So if you consider economist Richard Thaler from the University of Chicago, who was awarded the Nobel Prize in Economics in 2017 for his work in defining behavioral economic principles and for helping to shape and develop the field called behavioral economics, he wrote a book for the lay public, that's us, so anybody who's not an economist, called Misbehaving. And it's a term that he likes to use and is fond of using. And he describes it as any observations, economic observations, that don't follow the expected mathematical and economic principles that are so well known to his field. And he started delving into these observations and trying to understand why they occur. And over time, he and his colleagues discovered that these atypical economic observations can be due to predictable aspects of human behavior. And I highly recommend this book. I'm not trying to sell it for any reason, but it can be quite funny, and it was not only informative, but very entertaining at times. So I bring this up because if a storied field of economics was able to learn a great deal from the study of what Dr. Thaler calls as economic misbehavior, so too can we learn a great deal about Alzheimer's disease, really by looking closely at atypical clinical presentations, meaning those not presenting with memory problems, thus looking at situations where Alzheimer's disease is misbehaving. So let's delve again a little bit deeper into posterior cortical atrophy and really start with, well, why does the posterior part of the brain, why does that represent vision? Well, to understand why it does, we have to sort of understand that the brain does have functional segments or functional lobes or functional areas that are sort of experts or are the important parts of the brain that are responsible for those functions. So if we look at the frontal regions of the brain, that's where motor functions are processed and motor commands are given from our brain. And then the language centers also are present in the frontal regions. The temporal regions, there are important areas for memory. And then in the parietal regions, those are important for sensations. So feeling things on your skin, understanding where your body is in space. And then the back part of the brain, called the occipital lobe, is important for vision and visual processing. And the visual area really contains billions of neurons, and they distribute their signals to other parts of the brain, and frequently to the parietal areas and the temporal areas as the very first areas for processing what we're seeing. So all of that information that's coming in from your eye is processed and then put into, we'll put it this way, put into the visual area in that back part of the brain. And then that visual area processes it further and then sends it for what we might think of as more of the action of what we do with that information to the parietal lobe. And then for processing what we're seeing, that information gets processed down into the temporal lobe. So when you're looking at something, being able to recognize it will happen through the temporal lobe, and then being able to understand what to do with that information, like how to reach out for an object or how to avoid an object, that information is processed through the parietal lobe. So we'll stop here for a poll question.
Okay, everybody, it's time for our first poll question. And it is true, false. Vision is in the back of the brain. Audience, is that true or false? Go ahead and quickly submit your answer. If you have any trouble whatsoever, you can put your answer into the chat box. Once again, vision is in the back of the brain. Is that true or false? Okay, we'll give it just a couple more seconds. And let's go ahead and release those results. Okay, great response from the audience. I'll give it back to you, Dr. Pellick.
Terrific. Thank you. And thank you, everyone, for really knowing right away that vision is in the back part of the brain, because that really will help us with the next part. But if you didn't get it, we're going to review it a little bit more. So here we go. So the visual brain, as I had just introduced, really helps make sense, or helps us make sense of what we see, and also helps us act upon what we see. So here are these disparate pathways that also intermingle. One is a pathway that leads from that back part of the brain, called the occipital lobe, which can be divided up into 3 areas. They're labeled here as V1, V2, V3. Those are what I'd like to call the technical terms for specific areas within the occipital lobe. And when they process information, they send it elsewhere. And as I mentioned, it'll send information forward to the parietal cortex. And that pathway is referred to as the dorsal pathway. And some people, for shorthand, refer to it as the where pathway, because it's for spatial understanding and then spatial actions, because a lot of the information in the dorsal pathway, or in that where pathway, goes directly to the frontal lobes. And our frontal lobes, as you saw, are areas that are really important for action, as well as something I didn't discuss, but is really important for decision making. And as you also saw, is important for our language. And then the pathway that goes inferiorly, or what we call ventrally, into the temporal lobe is the what pathway, or the ventral pathway. And that's to allow us to recognize an object as a face, or recognize the color of an object, or recognize a building that we have seen before. And obviously these 2 pathways look like they're not converging here at all. They look like they're going on a separate trip, but these pathways intermingle with each other. So as just a very cliched example is, if you see a tiger roaming the streets because it escaped, in our world, from the zoo, your first thought will not be, what is that? That is an animal, and that's one that I need to be afraid of. And so therefore, what should I do? Okay, now I believe that I should get away from it somehow, not go towards it. So this all happens in a split second, and that's why we know through actually lots of detailed studies that these pathways are very much in tune with each other and share information. So that as soon as you see a tiger, you recognize that it's a dangerous animal and you need not to go towards it. You need to get away from it. So that's just an example of how these pathways really interact, but it also gives you a good understanding of what could happen when these pathways start to be affected by a disease like Alzheimer's disease. So now I'm going to show you what that might look like. And I'm going to present to you a patient who presented to me after struggling to understand what his diagnosis was and struggling to understand what his doctors really thought was going on with him. And he came to me at 70 years old after seeing many physicians multiple times over. And he actually came in with a typed list of symptoms that his family and friends put together for him. And mind you, he had 20/20 vision, and he described all of these as being very difficult for him. So when he tried to read, he had great difficulty, and this progressed to no longer being able to read newspapers, books, magazines, or other documents. And when it came to trying to read cursive, he was unable to do so, and he couldn't write in cursive very well either. And even when he tried to just print without writing in cursive, it was difficult for him. He was also describing problems with depth perception. He couldn't see stairs, curbs, bumps, or holes, or judge the depths associated with those. He was misidentifying colors. He couldn't see things right in front of him, so he had to use his fingers to feel around in order to find an object, as he wrote, such as a doorknob or a dining utensil or light switches. He was misunderstanding spatial relationships. So if somebody went to hand him something, he couldn't reach for it properly. He was also experiencing double vision at times, and he was misidentifying objects. So he saw a ketchup bottle for a lemonade glass or a candle for a salt shaker, things like this. And this all affected, as you can imagine, his functional activity. So he couldn't use remote controls, phone keypads, so meaning using his phone, computer. He was misplacing objects because he couldn't find them. And so really everything had been impacted in his daily routine, including not being able to drive, not being able to work on important documents anymore. And so I want to talk a little bit about why PCA is so difficult to recognize. This was a person who hadn't been formally diagnosed with posterior cortical atrophy syndrome. And I was able to do that with some additional examples on examination. And of course, the history was a very important part of the diagnosis as well. So why is recognizing PCA, why is it so difficult? Well, oftentimes, like in the case of my patient, people present with only one issue initially. When they present with a whole constellation of problems and have all the findings on examination, that makes my job much easier. But one of my goals is to get our diagnosis of PCA, to get it done earlier and earlier, because it is very different. If somebody presents with memory problems, we often have a very short list of the problems that it could be, and Alzheimer's being at the top of the list when a person is 65 years or older. And so we also want to make PCA at the top of the list when people present with healthy eyes, but difficulty with even one symptom, such as difficulty reading, not being able to find something in plain sight, or having depth perception impaired. So having only one issue and having lack of awareness for PCA, this can lead to delay in diagnosis. And I want to show you in what ways we're working to try to change that. And just attending this seminar or webinar is an important way for you to be able to recognize those symptoms, whether it's in you or in other people that you're taking care of in one way or another. So I'll stop here again for a poll question.
Okay, so poll question number 2, difficulty reading is not a symptom of PCA. Again, difficulty reading is not a symptom of PCA. Is that true or false? Go ahead and select your answer. We'll give it just a few seconds here. Again, if you have difficulty, please submit it to the chat box. Difficulty reading is not a symptom of PCA. Is that true or false? Let's go ahead and release the results. All right, pretty good job, everybody. Back to you, Dr. Pellick.
Thank you so much. And it is a great job because it really is the #1 symptom that comes to the office of a neuro-ophthalmologist. And neuro-ophthalmologists mostly receive patients from ophthalmologists. They also see patients referred from neurologists, but it appears to be the #1 symptom for PCA presentations to a neuro-ophthalmologist, and it is the top 3 symptoms presented to a neurologist for patients who are eventually diagnosed with PCA. But because of this difficulty with recognition, I led a group of experts who have expertise in atypical Alzheimer's disease as well as PCA to make recommendations for clinical assessment tools to help people make a diagnosis, which are clinicians make a diagnosis of posterior cortical atrophy. And we did this through a consensus, meaning we all worked together to come to an agreement, but we also sent surveys out to other experts in order to understand how people make a diagnosis of PCA in terms of what tools they use. And we did that survey and recommendations on the basis of the known features in the diagnostic criteria. So I just wanted to introduce that to you because this will also kind of round out your understanding. But in 2017, a group that I was also involved in, but was led by Sebastian Crutch, a neuropsychologist who has really helped to define the field and the field of study for PCA. He's at the University of College of London. He led our group to coming up with a set of diagnostic criteria. And at the top of the criteria is you have to have all 3 features of having a condition that's insidious, with progression that's gradual, and prominent early disturbance of visual functions and or other posterior cortical functions. And then you have to have at least 3 PCA features. And these 16 features listed here are sort of listed in what I would call neurologic speak. So they're listed in neurologic terms, but some will be easily recognized, like space perception deficit or object perception deficit. And then things like alexia, you can think of just like dyslexia is difficulty reading. Agraphia means difficulty writing. You can have finger agnosia, inability to recognize which finger is which, and then some problems moving your arms and limbs to specific areas of space, problems recognizing faces. And the list, as you see, is 16 core features. And so you must have 3 of those that cannot be caused by other problems like a stroke in the back of the brain or vision loss due to macular degeneration or those types of problems. And then imaging, like an MRI scan, can support the criteria. So with those recommendations, we took each of those core features that require assessment tools to diagnose, and we gave our readers and other clinicians who are interested a list of tools that they can use to make this diagnosis, or at least diagnose each one of these features, regardless of whether it's caused by the PCA syndrome or another syndrome. And we also included recommendations for a rapid screening battery that eye clinics can use. And these are our recommendations listed here in blue. We essentially say you should do a visual field, and then if you find at least 2 of the following tests abnormal, then this is a person that has a high likelihood of having a cortical visually based problem. And we go even further and we give them actual instructions on how to use a tool for screening patients. And this is something that's available within this particular research article, and the research article is available online, and you can click on a link to get these types of instructions, for instance. And we hope to use this information to spread awareness about PCA, but also to make sure that we're able to give tools to our ophthalmologists and optometrists and neuropsychologists so that when they're seeing patients that have cognitive or brain difficulty, they can easily access these types of tools and be able to improve early diagnosis. And then, of course, the rapid screening battery, we had in mind doing anything that can be quickly done in an eye clinic. So now I want to give you some examples of what we might see. So we've seen how it can be very difficult. And even when a person first presents, they can have a whole constellation of symptoms because they've had a delay in their diagnosis. But then I've also informed you that sometimes it can present with just one symptom. So now I want to show you, well, what does that look like, regardless of whether we're at the middle stages or the very early stages prior to diagnosis, what that might look like to a neurologist or an ophthalmologist who's using proper tools to understand a person's symptoms. Well, here's a very good example taken from my patients of that neurologic term that we call constructional apraxia. That's a mouthful, but what that means is when you look at a diagram, your goal is to look at the diagram and then copy it by hand. And if you cannot copy a diagram by hand, it's called constructional apraxia. And we do tend to use easy diagrams for copy, but if you have constructional apraxia, you have some areas of the back part of the brain that don't allow you to process that visual information and then put it into a motor command that allows you to copy the diagram. It can be very difficult. And if we look at the very top half of this slide, you'll see an example of a person with, who was 74 years old, and he had 24 months of symptoms of memory difficulty. And eventually we diagnosed him with further study with typical Alzheimer's disease. And here is his copy of that diagram, and it looks good. He passed. It's not perfect, but that is a passing diagram. And then 5 years after his symptom onset, you can see that he struggles because typical Alzheimer's disease will start with memory, and then these other type of features like constructional apraxia will come a little bit later. But here's a patient with PCA who's 65 years old, because 85% of patients with PCA will present before the age of 65 with symptoms. They may or not, I shouldn't use the word present, they'll develop symptoms to before the age of 65, but a whole 15% will develop symptoms after age of 65. But this is a good example of somebody who's had symptoms. It wasn't really clear how long symptoms started, but it was estimated to be 6 to 12 months after symptom onset. And here's an example of their evidence of constructional apraxia. So their diagram reconstruction was very poor. And this was only 6 to 12 months after recognized symptoms. Now, we also had available to us the drawing of the clock that the patient made. And clock drawing, as many of you know, is something that's commonly done when you go into a neurologist's office or you're seeing a neurologist and noting problems with memory or cognition or thinking. And although, again, not perfect, did well enough to generally pass that clock drawing test. And then 3 to 4 years after symptom onset, again, we're not 100% sure when the symptoms started, but at about 3.5 years, unable to really draw anything that even sort of resembles the diagram that he was trying to draw, and then clock drawing has become much worse. So this was an example that you can see that even with a simple test for somebody who's complaining of visual symptoms, a simple test like this, failure at it, if it's done in an optometrist or ophthalmologist's office, could lead to an earlier diagnosis. And it's something that neurologists have been doing for, decades. but it is not something that your eye doctor will typically do. And so we're trying to improve recognition. So if people are complaining of visual symptoms, the eye doctor's not finding anything wrong, this may be a test that they could think about in the proper situation. So now I'm going to show you some videos of people with posterior cortical atrophy attempting to interpret visual images. And the video on the left is an example of somebody trying to interpret images of overlapping line drawings of objects. So there's 4 objects. One is a saw, one is a cup, one is an umbrella, and one is a pear. And their job is just to name those. And you'll see that while trying to name them, gets through 2 of the 4, but then has difficulty with the other 2, and the overlapping lines causes some confusion for him. And for both of these, we have permission to show their audio without showing any of the video of their person, their face. So let me start with this first one.
Without connecting them, just, broadly what I see. Okay, so here's a saw and a saw blade, and it looks like an umbrella, and they're all mixed together in a way, like if you would have just piled them on top of each other, potentially. So what I see...
What else do you see? You saw a saw and an umbrella. Anything else?
Saw and an umbrella. What? Well, I don't know. Let me see now. You got me looking again here. A saw and an umbrella, and I think that's about all I can. Oh well, this looks like maybe like another part of a tool up here. I don't know what that would be though.
Okay.
It almost seems more like the person, it's a red herring or something, but okay.
So what he was saying is that it almost seems like this is a red herring, like it was thrown in there to sort of throw us off as to what we're looking at. So certainly had no problem seeing the saw or the umbrella, but you can see how a person can look at these overlapping images and not be able to see all of them and not be able to understand what they're seeing. And we think that this is a very good way to pick up people with PCA. It will also pick up people with typical Alzheimer's disease a little later in the course. And there are other images with more than 4 overlapping objects. So it can go all the way up to 12 for people in the very, very early stages. And now this next video shows you a gentleman, again, I diagnosed with posterior cortical atrophy, who was trying to interpret this image, what he was seeing, which is an image of an M, and the M is made up of very small capital letter B's. And so you can see him work through this, try to figure out what it is that he's seeing. And he sees the local images, but can't see the overall global image of an M.
Okay, what do I see on this page? I see bees. Not bees, flying bees, but the letter B's mixed with the letter D's, B's and D's.
Anything else?
I don't think so.
And do the bees make up a pattern that shows you a different picture if you put all the bees together?
B's mixed in with D's. Just B's. I don't see any.
So he was able to see the B's, although he mistaken some of the B's for the letter D. But he was not able to see that when he puts all those letters together, it really forms the shape of an M. And again, this is another screening test that we recommend for use in an eye clinic. but I also use it in my clinic when I'm trying to sort out whether somebody's visual symptom may be due to the brain when their eyes are healthy.
Okay.
So I don't want to end with giving you the impression that Alzheimer's disease is the only disease that can lead to posterior cortical atrophy syndrome, because there are other dementing illnesses and diseases that can cause visual brain dysfunction that show up as posterior cortical atrophy syndrome. So this does include dementia with Lewy bodies, Parkinson's disease dementia, cortical basal degeneration, and Creutzfeldt-Jakob disease. And I also want you to keep in mind, as I had previously alluded to, that posterior cortical atrophy syndrome can also present in somebody who is in their 50s. So it can be a young onset Alzheimer's disorder or a young onset disorder of those other diseases that I just mentioned. And that is another reason why there can be a significant delay in recognition, because expectations are, if you're coming in your 50s with problems with vision, is that you need reading glasses, or maybe you're developing a cataract early, or things like that. So it's not expected that somebody will come with a focal onset of a dementing condition. So again, leading it to have another feature that makes it less likely to be diagnosed earlier or appropriately on time. So I'll turn this back over to Dr. Bailey. This is our next poll question.
Okay, and Dr. Pellick, you're giving me an honorary PhD. I'm an MS, but thank you so much. All right, our third poll question is another true false. Other diseases can cause visual brain dysfunction. Is that true or false? Go ahead and quickly weigh in. Again, it's a true false. The statement is other diseases can cause visual brain dysfunction. True or false? All right. Well, I think everybody should be just about weighed in here. Let's go ahead and release the results. And 100%. Awesome job, audience. And back to you, Dr. Pellick.
Well, thank you. And I want to give you that honorary degree, and everyone else who's attending this, their doctorate degree in PCA. So I hope that's happening. And we're right at the end here. I just want to let you know about our support group. You can find it just by Googling Colorado PCA support. You can use this QR code. You aim your camera at the QR code on your smartphone, and you'll be able to get to our web pages quite easily. And we meet typically online. We used to meet in person, but because of COVID, it's moved to online. We hope one day to be going back into having meetings in person. So a lot of times the support group is informational, but we've also now transitioned to opening it up much more for people to support each other. But we do both, because some people are very interested in information and less interested in sharing. But we hope you will also find our web pages a great resource for you. So we look forward to seeing you and to having you sign up for our emails and coming to our web pages to learn more. And I also just want to end with a very successful recent research study that we undertook to try to better understand how posterior cortical atrophy syndrome changes over time and what measures we need to use to understand how people change over time. There are many people with posterior cortical atrophy syndrome that are frustrated at not being able to be in clinical trials for treatment. And what we want to do is figure out if we can understand how they change and with what measures to use to see how they change, then enrolling people in clinical trials will be much easier to do. Oftentimes, people with posterior cortical atrophy syndrome are not eligible because they don't have enough memory loss. And if we had better measures for understanding how posterior cortical atrophy syndrome changes, then we'd be able to enroll them in a clinical trial to see if certain treatments are working or not working. So we're very excited that we've had successful enrollment. And in fact, we just had our first patient go through, our first participant go through their 6-month follow-up just the other day. So now we'll turn it over to questions, and I look forward to hearing from you.
Okay. Oh my gosh. That was an awesome presentation. Thank you so much, Dr. Pellick. We really appreciate this very useful information. So just as I always do, I always insert a little bit of consciousness raising. We want to remind everyone of the importance of being aware of implicit biases, or otherwise known as unconscious stereotypes, as we care for others. A best practice is a person-centered approach where we view each person that we care for as an individual with unique needs and preferences. And of course, we treat them with dignity and respect, even if they are very different from ourselves. If we always listen carefully and respectfully so that we can understand their perspectives, values, and preferences, we can build trust and, of course, provide the highest quality of care. So now, if you have questions for our presenter, please be sure to type them into the chat box. And we'll get those organized. But before we begin that, I just want to take a moment to thank our sponsors once again: O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, and of course, Alzheimer's Orange County, which is our home base. We've got several webinars coming up that I want to call your attention to. Tuesday is our monthly webinar series, and the topic is cultural awareness in dementia care. That's Tuesday, May 14th. And then we also have, let's see, on May 29th, a non-CE presentation, but it's called Caring for a Parent That Did Not Care for You. So that's May 11th at 11 o'clock. There's probably others that I should mention, but you can always go to our website at www.alzoc.org to learn more about our educational offerings. All right, so now let's get down to the questions for our presenters. The first one is from a spouse. His wife has every PCA symptom, and she is in fact diagnosed with it, and she's in the late stages, or stage 5. So his question is, will she start losing frontal cells and start exhibiting Alzheimer's symptoms?
So if the PCA syndrome is due to Alzheimer's disease, then yes, the symptoms that we typically associate with Alzheimer's disease, the memory symptoms, some of the language symptoms, and even some of the behavioral symptoms can be a part of the very late stages of PCA. So although it starts differently, it will progress to develop some of those symptoms that we're more familiar with as being part of Alzheimer's disease.
Okay. Thank you so much. And then someone had a question about the videos. They wanted to know if the gentleman's vision was okay, or if it was nearsighted or farsighted. Did that have an impact in any way on what he was interpreting?
Absolutely. So that's really important, that the vision is that you have from your eyes, your ability to focus, that you don't have a cataract, macular degeneration. Those are all very important before you can immediately say that this person's problem interpreting visual information is due to a brain issue. And that's one of the things neuro-ophthalmologists do. And so even with some who are experts in Alzheimer's disease, they're concerned enough that could their visual problems be due to something other than the brain, even though they might think it is, they'll send patients to an ophthalmologist or to a neuro-ophthalmologist to say, hey, can you make sure that this isn't an eye issue? So ruling out eye issues is critical. That doesn't mean that people with glaucoma or macular degeneration cannot present with this And in fact, we have seen people with glaucoma present with this because they're getting every year, they're getting visual fields, and all of a sudden a visual field is showing up as being a brain problem, not an eye problem. So you can have eye diseases with this, but it's very important. It's included in the criteria, as well as just being good clinical practice, that both of the gentlemen that you saw did not have a problem interpreting visual information because of their eyes.
Okay, thank you. I wasn't sure if that was two separate people. Thank you for clarifying that.
Yes, they're two separate people.
Yeah. Okay, good. Could you, one of our attendees is asking if you could go back to the slide of the other diseases that feature visual effects, because that apparently is not in the handout.
Oh, okay. Oh, that's probably because of the animation.
Okay.
Yes, so you probably saw the overlay of the animation.
Okay.
Here are those other disorders, other diseases.
Okay. Great. Someone is asking, is there treatment?
So we know that posterior cortical atrophy syndrome is due to a specific disease. And if you're able to diagnose that disease, then yes, absolutely, there's treatment. So let's say you're able to confirm that the PCA syndrome is due to Alzheimer's disease. We now have FDA approval of the drug Leqembi, which removes amyloid from the brain. And people with PCA are eligible for Leqembi like any other person with Alzheimer's disease that's in the mild cognitive impairment stage or the mild dementia stage. So as long as you meet criteria of having mild dementia or mild cognitive impairment, which many people in the early stages of PCA would, then you are eligible. And I do have patients with PCA receiving Leqembi.
So that is really predicated on people getting an early diagnosis, which is pretty, as we said, is pretty difficult with this illness.
Exactly.
So yeah, so there's webinars like this help to raise public awareness, and I'm sure you're doing that all over the country. So thank you for that. What things can families do to help those with PCA?
Another really good question. And what we have found is that the more they know about why a person is behaving visually a certain way, the easier it is. So we have put together a handout that's available on our web pages that is an educational handout about what happens when the visual brain is not functioning well. And I'm going to give you one example that we hear, I would say 9 out of 10 times when I'm seeing patients over, 1 or 2 years, I will hear this being discussed, which is when my family member or spouse or caregiver, whoever it is, tries to rush me, I suddenly am not able to see as well. And so we know that when emotions start to hijack our brain, we all have difficulty with processing information, because typically an emotion is there for you to process that emotion. So if it's fear, you need to process, what am I afraid of? What do I need to get away from? If it's depression, processing that emotion is really important to get over. I shouldn't say get over, because that's not always what we want to do, but I was going to say get over grief, but grief is a process too. But so those emotions are there for you to recognize that there's something, just to put it quickly, there's something to deal with, and I need to deal with that quickly. But what happens during high level emotions is it sort of hijacks our brain and doesn't allow us to slowly process information. And with PCA, oftentimes the slower somebody is able to take their time to process visual information, the better they'll do. So one of the really important pieces of advice I can give is anybody with PCA or any type of visual brain symptom that comes from even after a stroke or one of these other diseases, doesn't have to be just Alzheimer's disease, is to allow your spouse or the person that you're with PCA to take their time. And so a lot of early prep work, if you want to get out the door to go somewhere, just know that it's going to take a lot longer, take longer to find things that they want to take with them or clothes that they want to put on, or just wrap their head around the fact that they're going to have to go out and be around a lot of people, because being around a lot of people, it can be visually confusing. So we have a lot of information just like that in that handout, and I can also send it to you, Kim, if you wanted to hand it out to others. I can also send that document as well.
Great. Couple people have asked about the current the Alzheimer medications like Aricept and Namenda. Are they effective for PCA?
Yes, and in fact, we frequently use Aricept, of course, as you probably know, for people with Alzheimer's disease of any type. And we use it frequently in dementia with Lewy bodies, as well as in Parkinson's disease dementia. There's less data in other dementing conditions, which I have listed here, but it's typically trialed. Although we do think it's critically important for memory in the memory pathways, it can help with certain other features. That's just never been proven. But let me give you an example. With dementia with Lewy bodies, we find that fluctuations may be less likely. And fluctuations are changes in your ability to process and think and hold on to information. And that can happen in hours to minutes to even over days. And what we have seen, again, anecdotally, not well studied, is that these fluctuations can remarkably change and improve so a person's more stable. So yes, I do use Aricept in people with PCA syndrome. It's really targeted at trying to support memory functions, but there may be some additional benefits.
Okay. Just a quick word here is that we're getting so many questions. So Dr. Pellick, you've said you can stay over
Yes,
for a
absolutely.
few minutes. Okay, that's great. And so just a reminder to all of you watching is that if you do need to leave right at 10:30, you'll get an email with your survey. You won't get it. It won't come up for you unless you wait till we end the webinar. Okay. All right. So let's go back to the questions. Can viruses trigger or contribute to the development of Alzheimer's or PCA?
Another really great question, and that might have been a very well-informed question, because there's some data recently, including coming from one of our neurologists who's also a basic scientist. Her name's Maria Nagel, and she studies the potential impact of viruses that are very common to all of us, like the zoster virus, the virus that causes chickenpox and shingles. And she believes that there may be a role in causing either brain inflammation or a response by the brain to keep the virus under control. And those types of responses can lead to the deposition of abnormal proteins. And it does appear, in the end, that Alzheimer's is not going to be a one, catch-all cause, that it's probably related to multiple causes. So genetic, environmental influences, as well as influences that we can consider environmental, like viruses.
Great. Is alcohol use a contributor to PCA?
So we know for sure that alcohol use that goes beyond moderation is a contributor to neuronal death. And so we don't think that it is the cause of Alzheimer's disease or the cause of a syndrome like PCA, but it most certainly can contribute to memory loss, confused thinking, and other cognitive domain problems. And even on its own, it can cause its own type of dementia, or it can lead to nutritional difficulties, or I should say not difficulties, but nutritional deficiencies that can lead to dementia. So alcohol can be an important contributor to dementia. It can combine with other causes of Alzheimer's disease to make dementia worse when these other diseases do occur.
Thank you, Dr. Pellick. Do you know of other brain jogs, so to speak, that can help visual processing in someone with PCA, such as, I think blinking was mentioned in the presentation, and also this person has heard of waving hands in front of the eyes. Anything like that that you can share? This person's an RN. She's working with several PCA clients.
Nice. So I hope that the document that we send will be helpful to you, because this was gathered not just from our center, and you'll see that in the document of where we gathered this information as well, but information from the University of Toronto, one of the first people to try to describe the criteria for posterior cortical atrophy, and who is really an excellent physician neuropsychiatrist. His name is David Tang Wai. He had put together a lot of information about symptoms and what people reported as possible ways around a symptom or to compensate for a symptom, based on feedback he had from his own patients, as well as based on his own knowledge and skills and understanding. And then this was added to by others, such as Sebastian Crutch, that I mentioned. And then we added some of our own information about how people have compensated and ways to consider this. But what you may be getting at with the waving of the hands or the blinking is what I like to refer to, this is not a great term, but I like to refer to it as resetting the brain. But essentially what it does is it sort of breaks that attentional barrier. So all of us run into attentional problems. If we're paying attention to one thing, we can't necessarily pay attention to something else. And in that case, if we just think about that in ourselves, if we don't have PCA, that happens to a really strong degree in people with PCA. So while they're tuned into one piece of visual information, they are completely tuned out to a lot of other visual information. And some people have described that second video that I showed you, where a person was trying to, my patient was trying to see the figure, but only recognize the local features, so the small B's instead of the big M. Some people think of that as a visual attention problem. And the idea that you can pay attention to only certain features, but have great difficulty with other things around what you're looking at, as well as what those features make up. And in that case, the little B, the capital B's made up the letter M. So by blinking or by waving your hands in front of your face, those may be methods to sort of break your attentional spell, I might call it. And one of the things, if you do look at the document, what you'll see is one of the things that we recommend is taking a break. If you're having a hard time finding something or doing something, stop, take a break, look elsewhere, get up, do another task, go get a drink of water, because that is a way to reset the brain, which may be exactly what you're doing with blinking and putting your hands, waving your hands in front of your face.
Thank you. And that answers a couple of people with similar questions. Someone's asking about gender distribution.
Very good question. So there appears to be a small signal that this may be more common in women than men. But the signal is very small and hard to separate out from the known signal that we already have with just Alzheimer's in general, which is it impacts women more than men. There are some studies that show, and again, all of these studies are really mostly retrospective, meaning let's look back and see who presented to our clinics or who presented in this large study. And see what the distribution is for gender. And again, most studies will show a slight increase in the number of women presenting, but nothing in a dramatic way, and things in a way that would seem consistent with Alzheimer's in general.
Thank you. This this gentleman is saying, my 53-year-old wife was just diagnosed with PCA. She was put on Namenda and donepezil. What do I need to do to get her, like, I can't ever say it, Leqembi? Yeah, I always mispronounce that. But how does she get that from her PCP?
Oh, very good question. So right now, most PCPs are not comfortable with prescribing it. So speaking to your PCP about seeing a neurologist who specializes in memory disorders, they're often called cognitive neurologists or behavioral neurologists. That's my second subspecialty beyond neuro-ophthalmology. And what we specialize as cognitive and behavioral neurologists is exactly that, determining whether or not Alzheimer's is the true cause of your condition, and then taking it a step further and verifying whether or not you're eligible for a drug like Leqembi.
Thank you so much. Any advice for a 61-year-old with PCA who is suddenly suffering from extreme anxiety? Could medical marijuana help? I just love all these questions.
It's
such a great range.
Absolutely, such a good question.
Yeah.
We do believe that anxiety may be more common in Alzheimer's disease than in the general population, so that it's not just a response to your condition. Because if you look at people with other medical conditions, it may be less common. So in general, anxiety can be a big part of dementia and may be due to the brain changes that are taking place, not just a reaction or a tendency that's based on psychology or something you can control. So that's the first thing to note. And the second thing is that there are a lot of signals that show us in studies that show us that anxiety may be a greater feature for conditions like posterior cortical atrophy syndrome. And some people argue that that may just be because they have better insight, but there are other signs that this may be because of the specific types of brain changes that take place. And so anxiety, I just want to finish those thoughts with anxiety is very common with PCA and with dementing illnesses, and it often isn't something that you can control on your own. So typically, people will function better with a combination of medications as well as therapy. And for years, people stayed away from therapy thinking, well, it's dementia, it's going to progress. Therapy is not talking and learning compensating techniques or compensation techniques are not going to be helpful when you have a progressive condition. But we now know that that's not true. So that therapy with a neuropsychologist or a psychologist, along with medications to control anxiety, can really help you live better and function better.
Okay, so that would be better than medical marijuana. That's not your...
Yeah, I didn't answer that last part. We get that question a lot, and for probably many more years than other states, because medical marijuana was approved many years ago in the state of Colorado. So I've talked to many of my patients to let them know that I wouldn't recommend it as a medical treatment, but because it's legal in Colorado, that I caution them on several fronts, but that I would want to know what's happening if they do take it. So it's not something I recommend medically or something that I recommend recreationally for them. But if they decide, and I give them reasons why, but if they decide to, then let me know. And so what I've been hearing is a mixed bag. Some people will report that they tried it once and it was overwhelming. They had symptoms of paranoia and they experienced fear. And I've had other people report that they were more calm. And so it probably is very dependent on the person as well as on, the substance that you're taking in. And that's one of the big problems is although it's legal medically in, many states now and legally recreationally in many states as well, it is not a drug that is, monitored in terms of what the impact might be with that particular formulation. So you have to be very, very careful. And if you're going to experience taking a drug like that, like marijuana, that can alter your thinking, is making sure that you're in a very safe environment with somebody who knows you're taking it and can allow you to be safe in a circumstance where you might have an unusual reaction to it is really critical.
Thank you so much. What is, okay, this drug, I'm not going to pronounce it right. Leqembi?
Is that the Leqembi again, do you think?
No, they're saying MAKIS. BIE. Oh, maybe that is somehow what they're saying.
Oh, maybe that's Leqembi or lecanemab.
I don't know. Leqembi, maybe. I don't know.
Well, we can talk about Leqembi.
Couple people have asked this question about this MAKIBIE. So, oh no, it's just one person. Okay, I think that person's mispronouncing it.
Okay,
So I think you've talked about that. So I think we can. Have you talked about that?
well, I can speak to it a little bit more.
Okay.
And that Leqembi is an infusion that you get every 2 weeks. And the infusion is made of an antibody. So it's antibodies going into your vein and then circulating throughout your body. And it binds to plaques in your body that are made of amyloid, the protein that accumulates in an abnormal degree in the brains of people with Alzheimer's disease. And in healthy people, plaques can also be found. And then by binding to it, it sets off a reaction that the body then gets rid of the amyloid. So it essentially clears abnormal buildup of protein called amyloid, of the protein called amyloid, and gets rid of those out of the brain. So that is how it works, and it is necessary to take it every 2 weeks. And the studies went through 18 months. And by the end of 18 months, the Alzheimer's plaques were cleared with that drug.
Thank you so much. We've got 2 questions left that we can attack. One is white matter brain disease the same as Alzheimer's disease, or is it related to MCA in any way?
Okay, so white matter disease, those are the arms of the cells that we call neurons. So white matter are the axons, which send the signals from the mainframe computer, if you will, the neuron cell, and use those signals to communicate with other neurons. And when those neurons are affected, we usually think of that as the cell body in the cortex. Well, when their arms are affected, the axons are affected, otherwise known as white matter, you can also develop dementia. And we know that these diseases I have listed here on this slide are diseases that can also affect the axons. So white matter disease can happen in all of the diseases listed here, in all disorders that cause dementia. But there is a specific type of white matter disease that is due to vascular disease. So meaning people who have multiple strokes or who have high cholesterol or diabetes, they can develop dementia just from impacting the white matter. And so when you hear white matter disease, it's oftentimes due to vascular disease or due to toxicities. Like white matter disease can happen with alcohol too. So in many ways it's connected, but when people specifically refer to somebody as having white matter disease, we're usually talking about the axons and not the neurons.
Okay, and then we're gonna end with a controversial question.
Okay.
That's a little bit far afield, but it can relate. They want to know your opinion on the Bredesen protocol.
Okay, so yes, you are right. That is very controversial. And I don't want to speak for all neurologists, but I can tell you the general opinion is that the Bredesen protocol is not a proven technique. And that may be the best way to put it. And of course, despite what you might hear, it's not a technique that has been hammered out using the typical method, which is peer review and using a way to put people through different approaches, like the standard of care versus the Bredesen method, and then in the end, determine whether one is superior than the other. And it also has not been looked at in a way that helps us know, is it cost effective? Meaning, can you get the standard of care? Can you be treated by your own physician what I might call aggressive way or assertive way, because you're doing a lot of work on your own, but being guided by your physician. And I think that's the main problem that we as neurologists and clinical scientists have with it, is that it's not a obvious advantage to doing all the things that we know are useful to preventing aging in a negative way, that we could do without a sort of large program that may be very expensive and out of reach for some people.
Thank you so much for that, Dr. Pellick, and for all of the incredible information you have shared with us today. Many comments in the chat box are about the effectiveness of your presentation and how clearly you speak about this topic. And so lots of accolades are coming your way, and I'm sure they'll be reflected in the surveys as well. So this is the end of our webinar, and we thank you, Dr. Pellick, for spending your time and expertise with us. Do watch for these upcoming webinars that I mentioned to you earlier, and go to our site at www.alzoc.org to learn more about them. And we thank you. The survey will be popping up when we close the webinar for everyone. And so we'll see you next time. And until then, take care.